So this is mostly review. This is just talking more about GI loss in peds specifically. So we talked about in kids and infants, they are more water percentage in their body. So fluid and electrolyte losses hit them harder. Because it happens a whole lot faster and they can't handle it super great. So usually this is going to be things like GI bugs. But it can happen from like other abnormalities that they're born with. The thing about kids is like abdominal pain, it can be very non-specific. So even though we think appendicitis is like right lower quadrant, sometimes kids will have like diffuse abdominal pain. And so we have to get a better history about what exactly is going on. This is just a lot of different things that can cause GI losses. Again, like I told y'all, like when I was a child and I just decided I didn't like the way water tasted, so I just refused to drink it. Sometimes kids are like that. You give them all the options and they still just don't eat or drink. Or maybe it's an electrolyte imbalance because they refuse to eat a vegetable and all they eat is chicken nuggets and mac and cheese. Okay, most kids go through a phase like that. Most of them can handle it just fine as far as their fluid and electrolyte status, but some of them it's going to affect. So lots of different things that can kind of affect how much fluid and electrolytes they're getting, okay? What labs are we going to do? These are going to be same in kids pretty much as we do in adults. CMP is just your complete metabolic panel. That's going to be the one that has all of your electrolytes on it. Normal ranges are pretty much the same for labs, for electrolytes on your pediatric populations. Your hemoglobin, that kind of stuff might change a little bit for your CBC, but your electrolytes are going to be the same. If we're concerned they have an infection and that is why they're having significant GI loss, we would do cultures, blood cultures, stool cultures. Guaiac is the blood in your stool test. Chest x-ray, abdominal, pelvic x-ray, all those things are just for infection or constipation, because constipation can also affect your fluid electrolyte status. And that shows up really good on a abdominal x-ray. Okay. The biggest thing in these kids is going to be fluid replacement, just giving them the fluids that they're not getting. We like to keep them NPO if we can, though we will often give them like anti-nausea medications. Like if they come into the ER and they've had a bunch of vomiting, we don't like to start IVs and give IV fluids to kids because it's really easy to fluid volume overload them. And also we just don't want to poke kids unless we have to. So our first choice is going to be oral hydration for these kids. So we might keep them NPO while they're actively vomiting, right? We don't want to encourage them to have more in their stomach to vomit, but once they've stopped, or if we give them like the Zofran or some kind of an antiemetic medication, we will then in the hospital do what's called a PO challenge, meaning we'll give them the medicine, we'll give it 30 minutes to an hour to kick in, and then we will give them a little bit of juice or a graham cracker or whatever else it is to see if they're able to tolerate it. Because if they are able to tolerate fluids or food with medication, they're safe to go home. If they continuously vomit and they can't keep anything down, that's when again, get more into the conversation of admitting the patient and kind of maybe doing some IV fluids. Once they start eating again, we start on the BRAT diet. Do you all know what that is? What's it stand for? Bananas, rice, applesauce, and toast. And that doesn't mean like toast with Nutella or J.O. or peanut butter, okay? That means like at the very max, just like a little bit of butter, but like really kind of boring, dry toast. All of those bland foods, they need to stay away from fried food, spicy food, all of that kind of stuff for a while. And that is not just in kids, y'all, that is adults as well, okay? So that's kind of how we get back to it diet. We talked about wet diapers for kids that are not potty trained. How many wet diapers do they need in a day? So it's every, 4 to 6 is kind of your bare minimum. 4 would be every, like, what is that, 3 hours? So if you're not having a diaper every 3 hours, we need to be concerned. Okay. And then obviously we're going to assess how dehydrated they are. In really littles, They will also weigh diapers so that they can get a really good, accurate output. It's not something they're gonna do at home, right? But it's something that we might do in the hospital. And then basically, for every gram, they say 1 gram is 1 ml. And honestly, when my daughter was in the NICU, they weighed diapers, and what they do is they put a dry diaper in the size that the kid wears on the scale, and they zero it at that, and then they pull the dry one off and they put the wet one on, and so that gives you the difference, and that gives you the actual weight of the urine. Okay. It is hard though, because a lot of like babies, they pee and poop at the same time. So it's like, how do you know what's urine, what's stool? I don't know. That's just, it's all output. So at the end of the day, I guess it's about the same. Okay, we just talked about all of this. If it's significant GI issues, we might put in an NG tube and kind of get everything out of the stomach. We can also use the NG tube to rehydrate. Okay. That's pretty much all that's here. Okay, so see, that's everything that I added to the PowerPoint that I posted yesterday. It's all basically a review of what we have talked about kind of on Monday, right? Don't have any questions?
You said 3 hours, it was 4 diapers.
You're right, 8 hours. No, seven.
You said
No,
every
yeah, I was wrong. Hold on. It was 6 hours. Every 6 hours, because that's 4 diapers a day. Minimum amount is 4 diapers a day.
4 diapers. Okay. I just heard.
Sorry, yeah, that was me. I did the math wrong in my head.
No, that's fine.
I did it backwards.
Okay.
Yeah, so every 6 hours would be 4 diapers a day.
Got it. So
But like, if your kid is older, they might not pee overnight, or they might have a really, really soaked diaper in the morning and then have less throughout the day. So that's where that weighing the diaper comes in better. 1 ml. That's for your actual Eisenhower sheet is 1 to 1.
So you're saying 4 to 6 a day?
Yeah. Mhm. Okay, so that really kind of finishes off our fluid part of the lecture. Do y'all have any questions about that before we move on to electrolytes?
I couldn't find validation. Where do I?
I posted an announcement and I updated it in the module. Yep. It should be the up-to-date one in the module.
It is.
Okay. But like I said, it's only those like 6 slides or whatever it was. Okay, so we are going to move on to electrolytes then. So electrolytes are pretty simple, to where if there is a deficit of the electrolyte, we give them the electrolyte. Okay. If there is an excess, we have to figure out why there's an excess and how we can get rid of it. Sometimes that's via medication, sometimes that's just giving the kidneys time to work or doing kind of dialysis on patients whose kidneys don't work. But other than that, it's pretty simple. But the big thing about electrolyte imbalance is we got to figure out what's causing it. Are they eating too much of something? Are their kidneys not working? Are they on too much of a medication? We need to treat that underlying cause, because otherwise, when we replace it, we're just putting a Band-Aid on the problem, and then it's going to continue to happen again. It's like having a stab wound and putting a Band-Aid on it. It's not going to treat the underlying cause, right? So we have to actually figure out why they are low. Okay. So we're going to talk about sodium, potassium, calcium, and magnesium. So the NCLEX does give you normal values for electrolytes and labs. And so we will give you normal values on the test. You just need to be able to interpret them, or we might give you signs and symptoms, and you would have to recognize what that is a sign and symptom of. Okay. So how I would recommend studying for this is like make yourself a chart of like low, high, and all the electrolytes, and kind of fill in what are the different signs and symptoms you're going to see. What am I emphasizing that I think is important, and kind of work on studying those. Because if it's something that is going to apply to a whole bunch of them, we're probably not going to ask you about that specific thing because it's going to be too hard to differentiate. So we're gonna ask you about like a whole class of symptoms, right? Or if an electrolyte imbalance has like one thing that really sticks out about it, that's what I would focus on. Okay. All right, so the first one that we are going to talk about is sodium. When you see sodium, I want you to think neurostatus. Those two go hand in hand. Both high and low can cause issues with neurological status. Okay. And so that is what I want you to think here. These down here are some causes. Okay, and these up here are some symptoms. So like I said, lethargy, confusion, seizures, coma. What are all of those things? Neuro. Okay. This can be caused by a lot of things, GI suctioning, diarrhea, if you're sweating a whole lot and not replacing your sodium. So if like someone is doing, do you know what an Ironman is? Like that really big triathlon? Okay, so if somebody's doing a triathlon like that, it's 200 and something miles, 240, I think, miles of exercise, swimming, biking, and running. If you're just drinking water and when you sweat, we get rid of salt, right? And so if we're sweating out salt and water and we're only replacing it with water, you're going to have a hyponatremia problem. Okay. We can get some issues with depending on the fluids that we're giving, right? Diuretics can also cause a low sodium. So here are some other things here. So like I said, think neuro. If they're not eating or drinking, excessive sweating, diuretics, suction is a big one. This is the syndrome of inappropriate antidiuretic. That's that one that holds on to water. So if we're holding on to too much water, then we get what's called dilutional hyponatremia, meaning our salt levels are consistent, but then we have too much fluid, making it a more dilute concentration, and that leads to signs and symptoms of hyponatremia. Okay. Too much hypotonic fluids. Don't worry too much about aldosterone. But kind of that fatigue, headaches, seizures. There is some muscle cramping in here, spasms of the muscle. That's one that like I'm not going to ask you just about like what electrolyte imbalance can cause muscle spasms or muscle twitching, because like literally all of them can. Okay, so it might be added on as an addition, but it's not going to be the only thing that we ask you. Okay, bless you.
Thank you.
I would think here more the neuro stuff, the fatigue, lethargy. Okay. So this is when your sodium level is less than 135. With all electrolytes, the more out of range your lab value is, the more significant symptoms you're going to have, right? Just like any other lab. So if my sodium level is 134, I'm probably not going to have symptoms. If my sodium level is 115, I'm going to have a lot of symptoms, okay? So that 135, 145 range, this is talking about anything less than 135 in most people, okay? Some people might start to have symptoms at 130. Let's say they're always at 140, like consistently. So then they might start to feel bad at 130 or 128 or something, versus other people might not start to feel it till 115, 120, okay? Greatly depends on the patient, but worry more about what are the signs and symptoms. Okay. Okay. Okay, then we have the hypernatremia. So this can be caused by too much salt intake. Osmotic diuretics, which is really only mannitol, and you don't really need to know a whole lot about that. Diabetes insipidus is that one where it causes you to pee a whole lot. You don't have enough antidiuretic hormone. And so in that case, you're getting rid of so much water, bless you, that you have highly concentrated salt. So that's why that can cause hypernatremia. Okay. Low water intake. And then kind of similar symptoms. This one you don't see nearly as much as the hyponatremia. Okay. But still think urine. Okay. Anytime you have high salt, your body's going to try and hold on to water, which is going to give you signs and symptoms of some fluid volume overload. Okay, like high blood pressure, headache, JVD, okay, maybe edema. And your urine output is going to go down because when you have too much salt, your body is holding on to water. So your body's not going to want to get rid of that water. Okay. Like I was telling y'all on Monday, this hyponatremia is the other thing that we give hypertonic solution for. So that 3% normal saline, we can give that to treat hyponatremia. Because at that point, it's less about the fact that it's moving water in and out of the cells. It's more about replacing the actual sodium. But we're only going to do that, like we talked about Monday, that's a very harsh medication on our veins. So we're only going to do that if their sodium is really low and they are symptomatic because of it. So if somebody comes in and they're at 115 and they are lethargic and, hard to arouse and confused, at that point, we're going to think about that. As far as hypernatremia, you're probably just going to treat this with fluids and try and dilute some of that sodium that's in the blood and hope that the kidneys can get rid of it for us. And again, the hyper is going to be anything over 145. Okay. Do y'all have any questions?
You said isotonic.
Probably isotonic.
Yes, hyper.
For hypernatremia, you would probably use the isotonic fluid.
Hypo, you said.
Hyponatremia, you would use a hypertonic solution, like 3%.
Okay.
Yep. You gotta think about you're low, so you want to give more salt, versus when you're high, you just want to give fluids to kind of correct their fluid status. So we don't need to be all that worried about pulling fluid out of the cells.
Okay, so hypo, you give hyponatremia, you give hyper.
Hyponatremia, you would give a hypertonic solution, yes. But not all hypertonic solutions, it would only be 3% normal saline. Because you're not giving it for the hypertonic qualities, you're giving it for the salt content.
Okay. And that's. Unless the hyponatremia.
Yes.
So the cause of electrolyte, basically.
Yeah, if their fluid volume is okay, or if their fluid volume depleted, like they're super dehydrated, and that's causing them to be a little bit hyponatremic, isotonic fluids are great. Yes, that's a good question. Okay. All right, so sodium, you're thinking what body system? Neuro. Okay. One of your first signs and symptoms that you're going to see about sodium imbalances is going to be thirst, especially with hypernatremia. Your body is going to just tell you you're thirsty and to drink water. Okay, so that's kind of an early sign. I think that's pretty much it. Okay, now we're going to talk about potassium. So if sodium is neuro, what do you think potassium is? Cardiac. Okay. This is a, yes.
Sorry.
Yeah.
So you said the levels, they will be on, right? But just no symptoms.
Yeah, like symptoms. Yeah. I'm not gonna ask you, like, a potassium level is 3. Is that hypokalemia? Okay, yes, obviously. Then we're not gonna be that easy. It's more gonna be like, these are your set of symptoms. What might you expect your levels to be? That kind of a thing. But if it's a specific question asking about a level, you'll have the normal. Because that's how NCLEX does it. Okay. So potassium is most important in the heart rhythm and some of that conduction of your neuromuscular impulses. Obviously, there's other things there as well, but those are kind of your two biggest things. So it has a lot to do with your cardiac muscle contraction as well as your skeletal muscle contraction. potassium, like, everybody agrees on sodium 135 to 145, but like, the hospitals are all different about potassium, and I don't know why that is. So if we can all agree that 3.5 is the lower end, but I've seen anywhere from 5 to 5.5 be normal on a lab panel. So just go based off of what your hospital says. If we give you something, it'll be like 6 or greater. So it'll be
High enough to know.
it'll be high enough to say that's not gonna be normal in anybody's range. Okay. But I've literally seen people say 5.5 is fine. I don't know why we can't agree on that one, but we can. Okay, so potassium is mostly found inside the cells. Okay. But we do need it to have muscle contraction in both skeletal or in all of skeletal, smooth, and cardiac muscle. But the biggest one to note is heart. Okay, so hypokalemia, so that is less than 3.5. Most commonly is caused by diarrhea, GI loss, and diuretics. It's often caused by like GI problems. Of course, I told you muscle weakness is going to be found on pretty much all of them. Okay. But also some neuro changes, not nearly as much as sodium. The biggest thing you're going to see here is cardiac arrhythmias. So with hypokalemia, this might look like a presence of a U wave on the EKG. I can show you a picture of that here in a minute. Okay, let me just try and pull it up. You like that? Oh, why don't do that? Don't do that. No. Okay, well. I'll just okay. So you might have, so this ST segment might actually be depressed, meaning it goes down, up on that line here. And then you might have this U wave present. So this is what happens in hypokalemia. Okay. So ST depression and a U wave. Okay. Usually we can fix a lot of electrolyte abnormalities with food intake, so they can eat potassium-rich foods. What are some potassium-rich foods? Bananas, potatoes, leafy greens. Okay, when you're taking a test, when in doubt, the answer is probably leafy greens. Okay, they've got everything in them, I swear. Okay, if you like have no idea, just pick leafy greens. So they're also high in potassium. The most important thing we're gonna do here is we're gonna get labs and we're gonna do an EKG. Okay. We will give potassium replacement. So we can give it PO. When we give it PO, has anybody given potassium in the hospital? Yeah. The pills are gigantic. Okay. And they are like chalky and people hate taking them. Okay. I almost always 98% of the time break those things in half because they're so big and so chalky that like almost nobody can swallow them. And I always bring like double the water or juice or whatever they're drinking that I think that they need because they're going to drink a lot of it to take it. If they cannot handle those, we have a liquid. We also have this powder that they can like mix into juice. Okay. So it just kind of depends on your patient, but we're going to give PO potassium for mildly decreased potassium that are asymptomatic. So maybe they're on Lasix So they're on a medication that's currently dropping their potassium. And their potassium level is 3.2. Okay, I'm probably just gonna give them a little bit of PO potassium to try and replace that. Because they're not having any symptoms. Okay, if it gets worse, we need to give it IV. Usually a potassium is ordered like in 20 milliequivalent dosages, so it's like 20, 40, 60, 80. Usually PO we don't give more than 40. In IV, we can give it, really it's like 20, the fastest you can give it is like 20 MEQs, which is milliequivalents over 1 hour. A lot of times they'll do like 20 milliequivalents over 2 hours. IV potassium burns. I've never had it. I have had a lot of patients in my career tell me that it hurts, tell me that they can't tolerate it. So apparently it hurts really bad. So we can always slow it down and give it slower than is actually ordered to try and decrease some of that pain. We also sometimes will run it concurrently or with normal saline. If they can handle a little bit of extra fluids, we'll just run normal saline at 50 mLs per hour or something just to dilute the potassium a little bit to make it hurt a little bit less. IV potassium has to be given piggyback or mixed into like a liter of fluids, slow drip. IV potassium push will kill someone. Okay. That is like, NCLEX loves to ask about IV push potassium. Okay. IV push potassium is one of the components of the formula that they use on death row to kill inmates. So it will kill them. Please don't do it. You really can't because it literally comes in like a bag. So you would have to just bolus in a bag of potassium, which would be crazy behavior, but don't do it. We are going to put it on a pump and the patient needs to be on a cardiac monitor while we're doing it. Because we want to make sure that it's not causing any EKG changes while they're getting the replacement therapy. Okay. We talked about this a little bit yesterday with really Lasix and hydrochlorothiazide do drop potassium. And so we need to be cautious when patients are taking those medications. And if they are on those medications and we notice they have a low potassium, we need to tell the doctor and maybe ask about getting a potassium supplement. We do not want these patients just getting a potassium supplement on their own off the internet, right? Because if they take too much, it can cause worse problems. Hyperkalemia is worse than hypokalemia. Okay. And then we have spironolactone, which holds on to that potassium and can cause hyperkalemia. So like we just talked about, the complication of hypokalemia is the flattened T wave or the inverted ST segment, or the presence of that U wave. Do y'all remember why it's dangerous with patients on DIG? Potassium and DIG have a really interesting relationship. And so if your potassium level go down, your DIG levels actually will go up, causing an increased risk of digoxin toxicity. So patients who take digoxin need to be on a consistent potassium diet. A consistent potassium diet, yep. But most of the time, this is caused by either diuretic use or significant GI problems, like vomiting or diarrhea, or prolonged GI suctioning. Okay, and what do we give diuretics for again? Fluid volume overload. Good. Okay. Here are some more, just another way of saying all the signs and symptoms. What I want you to think of is cardiac. Okay. Oh, here's a picture of your U wave. Can be lots of different ways. It's not usually there. Okay. All right. Here again is just the more, we talked a lot about a lot of these already. Different foods that are good for potassium. Okay, now we have hyperkalemia. This one is the more dangerous one. This one happens a lot of times in patients who are on dialysis. If they miss a dialysis session, we're concerned most about this one. Okay. This one, again, potassium has a lot to do with that muscle contraction. And so we might get muscle twitching in this one. Eventually, maybe some altered mental status, but here we're going to have our peaked T waves. So this one is saying that your potassium is greater than 5.3. Working in the ER, we have an interesting sense of humor. And we like to talk about what's the highest or lowest labs you've ever seen in patients that come in. So the highest potassium I ever saw was 9.8 on a living person, because people that come in dead, their labs don't count because it got the better of them. But on a living person, the highest potassium I ever saw was 9.8. He was alive. He was in VTAC with a pulse, but just hanging out in VTAC for like a long time. He was a dialysis patient. He had missed 2 dialysis sessions. And he was very sick. And we were giving him a lot of medications to bring it down, and it was not doing anything. And so he had to go to emergent dialysis in the ICU, and he ended up being okay, but it was scary for me. For the whole hour and a half I took care of him, I was concerned the whole time he was gonna die on me. So that is, crazy. I've never seen anything even close to that. Okay, so how we treat this, you don't need to know this, but if you see it done in the hospital, how we treat it is we try. So I told you earlier that potassium likes to be inside the cell, right? So when it's outside the cell, our body doesn't do as good with it. So the treatment for hyperkalemia is trying to push the potassium back into the cells. So basically we do that with a whole bunch of medications. Insulin pushes potassium into the cells. So we give IV push insulin. We give dextrose to kind of combat that insulin. And then we give calcium gluconate to protect the heart, and albuterol also pushes potassium into the cells. So we give albuterol. And then we give some medications that work in the GI tract that basically they induce diarrhea, because I told you earlier, diarrhea causes hypokalemia. So basically we just tell the body, hey, get rid of some extra potassium in the gut. And then it does. So that's kind of our treatment for hyperkalemia. So we want to protect the heart first. So we give that, it's called calcium gluconate. We give that first to protect the stability of the cardiac muscle. And then after that, we will give those other medications to kind of push that potassium back into the cells. But you definitely need to be watching their cardiac rhythms. What kind of EKG changes do you see on this? Do you guys know? EKG. Yeah, I feel like you were on the right track. What did you say? Nope, not AFib.
SBC.
It's actually just called a peaked T wave. So that T wave that usually looks like a hill, it gets really tall and spiky. So that is what, you can also go into VTAC eventually, but commonly you will see that peaked T wave. So there you go. Kind of a great comparison picture of the 3 different ones. So you have your normal at the top. You don't normally have a U wave. Okay, you can just ignore that up at the top. In hypokalemia, you'll have that depressed ST segment, or a shallow T wave, a really flat T wave, or the presence of a U wave. And then in hyperkalemia, you have a tall peaked T wave.
We need to know these.
I would know these, yes.
The EKG.
I would know what it looks like on an EKG. Yep. Because that's the biggest thing with potassium. Okay. Hyperkalemia will kill you faster than hypokalemia, so hyperkalemia is the more dangerous one here. Make sure. Okay, so questions about potassium. So sodium is what body system? Neuro. Potassium is cardiac. Good. Okay, that brings us to calcium. So calcium is mainly stored in your bones and your teeth. There's a little bit in our extracellular fluid, but not a whole lot. The reference value here is 8.2 to 10.2. I've seen 8.5 to 10.5. You're just gonna go based on what your hospital says. Okay. Calcium is one that little changes can have significant impact. Calcium does also affect the heart, and that's why with the hyperkalemia, we give a calcium medication to kind of stabilize cardiac muscle. So if we have things going wrong with our calcium, it can cause issues with our hearts. But some of the other big things here are going to be convulsions, arrhythmias, tetany, which we're going to talk about 2 tests that are going to test tetany. Say that 3 times fast. And then like laryngeal spasms or stridor. So if you're hearing abnormal lung sound or sounds up near their, like actually where they're breathing in their neck, that's going to be a sign of hypocalcemia. So moving along. So this is very common when people have their thyroid or parathyroid removed, because that is somewhere the organ that really kind of balances our calcium levels in our body are our thyroid and our parathyroid. So if you have those removed, it's going to put you at a higher risk for hypocalcemia. Women are at higher risk for this, especially postmenopausal. Also, calcium and vitamin D are interrelated. You need vitamin D in order to absorb your calcium. And so if your vitamin D levels are low, even if you're eating enough calcium, it might not be holding on to it well enough. So one of the first line treatments for hypocalcemia is actually a vitamin D supplement. Let's see if that helps. Okay. I had low vitamin D a few years ago, and my doctor that drew my lab, she was like, let's check a vitamin D. And I was like, why? I'm not having any symptoms, I think. She goes, all white women are low in vitamin D. And I was like, okay, fair enough. So she drew the lab, and she turns out she was right. My vitamin D was low. So it just kind of, that's one of the first line treatments for hypocalcemia. Okay. And then also calcium and phosphate, which we're going to talk about a little bit later. So hyperphosphate and hypocalcemia go together because they're inversely related. Okay. When you think calcium, think like muscle contraction. So like we're going to get a lot of muscle tetany. They might also get some tingling in your extremities. We're going to talk on the next slide about Chauvet's, I think it's Chauvet's, I can't say it, and Trousseau's sign. Those are early signs of hypocalcemia. We're going to talk about those on the next one. Late signs are going to be things like osteoporosis and patients with frequent bone fractures. Because if you don't have enough calcium, you're not putting enough calcium into the bones, they become more brittle. Again, that laryngeal stridor is a late sign, but a very severe sign of hypocalcemia that would need to be reported immediately. And again, that's going to be stridor you hear kind of up here. So we can give IV calcium if it's low enough. Okay. There's 2 kinds. IV calcium gluconate is the one that I was telling you about earlier that we can give through. It's like a IV piggyback, but we can give it over like 10 minutes. And then we have calcium chloride. Calcium chloride is a ACLS medication that you give to a person who's like actively coding. But if your patient's alive, you're gonna give them calcium gluconate. We're gonna increase their calcium intake in foods. Again, you're gonna treat the cause. Do they have a phosphate issue? Are they postmenopausal? Is their vitamin D low? We need to treat the underlying cause. Tums are calcium carbonate. So patients that have low calcium can actually just be put on Tums as a replacement therapy. So also think about if you have a patient who has chronic GERD or something and they take a lot of Tums, it can actually cause hypercalcemia. Okay, so people need to be aware of things because we just think, oh, Tums are safe, they're over the counter, I can take them whenever. Well, we don't think about they could actually mess with your electrolytes. But they do make other calcium supplements, but Tums is the easy one that's over the counter that they can just buy. And they're super high in calcium. Okay, so these are the two important things for hypocalcemia. I'm going to show y'all a video. I always remember, so CH chopstick, CH cheek. Okay, and then Trousseau's is, I've never seen this one in real life. I have seen this one and it was the weirdest thing, and we didn't even know that the patient had a calcium issue, and I just happened to be taking a blood pressure and I saw her arm kind of freeze up and I was like, oh my God, that's Trousseau's sign. I did not know that actually happened in people, but they really do. And so I always think of them as a combo, like Trousseau and chopstick together, and then I remember them, I just always put chopstick first in my brain, and C for chopstick, C for calcium. That's how I remember it. I'm gonna show y'all a video of what these actually look like. Come on. Excuse me.
Which one is the filter? The plus.
Hold on. Please stop.
She said it's supposed to be it also affects your arm.
Hey everyone, it's Sarah, registered nurse, RN.com, and in this video, I'm going to talk about Chebot-6 sign. So let's get started. Chebot-6 sign is a specific type of facial muscle twitching that occurs manually stimulated, and this demonstrates hyperexcitability of the facial nerve. It tends to be associated with patients who are experiencing hypocalcemia, so a low level of calcium in the blood, because many times these patients are experiencing irritability of their nerves and muscles. It can also be seen in patients who have a low magnesium level. So how do we assess for Chebot-6 sign? Well, we're looking for either a positive sign or a negative sign. Positive means they have it, negative means they do not. So first, you want to identify the location of the masseter muscle on the patient, which is located at the jaw's angle. Next, you want to tap on this muscle and assess the response of the facial muscles on the side that was manually tapped. If it's positive, the facial muscles will contract momentarily. Example, the lips will twitch. If it's negative, no changes will occur. Okay, so that wraps up this review over Chebot-6 sign. If you'd like to watch more review lectures, you can access the link in the YouTube description below. Hey everyone, it's Sarah, registered nurse, RN.com, and in this video, I'm going to talk about Trousseau sign. So let's get started. Trousseau sign is a specific type of muscle spasm that occurs in the hand and wrist due to neuromuscular irritability, which tends to be a definitive sign of low calcium in the blood, hypocalcemia. It can also occur whenever a patient has a low magnesium level in the blood. Now, how do we assess for a Trousseau sign? Well, you're looking for either a positive or a negative sign. Positive meaning the patient has it, negative meaning they do not. So in order to do this, you need a manual blood pressure cuff, along with being aware of the patient's latest blood pressure reading. Specifically, you want to be aware of that systolic number of the blood pressure reading, which is the top number. Next, you want to place the blood pressure cuff on the arm and inflate this cuff to a pressure greater than the patient's systolic number and hold it there for about 3 minutes. Now, while you are holding it there, you want to look at that arm that has the blood pressure cuff on it, specifically that hand and wrist. And you want to monitor the reaction that is occurring on that side. If it is positive, the hand will draw in toward the body and flexion will occur at the wrist, thumb, and MCP joints, but the fingers will remain extended. And if nothing occurs during this, that means that it is a negative Trousseau sign. So why does this occur? Well, whenever we place a cuff on a patient's arm and we inflate it above their systolic blood pressure, we're occluding the brachial artery. And the brachial artery gives blood flow to the structures down here, like your forearm, your wrist, and your hands. Well, whenever a patient has a low calcium level, their nerves and muscles are already irritable and too excited. So whenever we impede that blood flow, hence cause ischemia, it's going to cause these structures down here to spasm. Okay, so that wraps up this.
So that's kind of a good little video on what they are and what you're going to see on the patient. Okay. So again, those are for hypocalcemia. Like we were talking about, so calcium and magnesium are friends. They have direct relationships, meaning most of the time when you have a low magnesium, you have a low calcium. When you have a low calcium, you have a low magnesium. Versus phosphorus is opposite. They're inversely related. So if you have a high calcium, your phosphorus is going to be low. If you have a high phosphorus, your calcium is going to be low. Okay. Usually phosphorus is, we don't deal with this a whole lot. Usually it's going to be patients with kidney problems end up with high phosphorus levels, and so that will drop their calcium levels. But you don't need to know a whole lot about phosphorus. So what are we going to do for hypocalcemia? Well, we're going to increase their food intake. We're going to give them a vitamin D supplement. We're going to give them a PO supplement if we need to. We're going to give them calcium gluconate. And then we're going to watch for those 2 signs and symptoms. So really we have sodium is neuro, potassium is cardiac, calcium is smooth muscle. Of course, there's other things in there, but those are kind of the big ones. Okay. Okay. All right. Well, what are we going to do to increase our calcium intake? Most commonly, this is found in dairy products. Okay. So I would not, for one, be mad if you told me I needed to increase my cheese intake. I'd be totally fine with that. Okay. But yogurt, milk, tofu is pretty high in calcium. So usually your vegans, vegetarians don't truly have too many issues with, well, vegans maybe because they're not eating any dairy, but tofu is high. Again, spinach, those leafy greens, they've got calcium in them. And then some like legumes. Okay, then we have hypercalcemia. This is usually if their patient is taking too much vitamin D or too much calcium, or they have kidney failure or the hyperparathyroidism. Prolonged use of hydrochlorothiazide can also cause hyperkalemia. Or it can be an issue with patients with metastatic cancer, specifically if they're on the bone. I don't know that I have ever once in my career seen a patient that has hypercalcemia. So it is not nearly as common of the others. Okay. Okay. All right, then we have magnesium. So magnesium is also important for muscle contraction. Because think about it. So I just told you magnesium and calcium are friends, right? So if calcium has to do with smooth muscle, so does magnesium. Okay. So normal magnesium 1.6 to 2.2 approximately. Okay. They might have some confusion, some lethargy, some muscle weakness. Okay, so magnesium is also important for that neuromuscular transition. So like the brain telling the body to move and the body actually responding. And then it also works in the cell for a lot of metabolic reactions. So with hypomagnesium, you're going to see similar things to hypocalcemia. So you will have that chopsticks and Trousseau sign. And then also your reflexes are hyperactive. Same with hypocalcemia because everything is really excitable when it's low. So the calcium and magnesium are low. You have hyper excitable, oh my gosh, reflexes. Okay, again, green leafy vegetables, legumes also. Nuts are high in magnesium. Okay, so then we have hypermagnesium. So did you guys learn about magnesium in women's health at all? Did you talk about that with preeclampsia, mag sulfate? Okay, so just to tell you, I had to get mag sulfate when I was pregnant because I had preeclampsia, and magnesium makes you feel horrible. Like when they tell you they feel bad, horrible. I felt like I got hit by a train and then it like stopped and then back over me. Okay. You feel like you literally can't even move your limbs. Your reflexes are very much delayed and not nearly as much, your reflexes are much less. Okay. That's why in women's health, when the patient's on magnesium, it's like the one place in the hospital that they're checking reflexes. Nobody else in the hospital is bringing out a reflex hammer, but labor and delivery for a patient on med. Okay. Hypotension. It is a smooth muscle relaxer. That means it's going to relax all of your vessels as well. So hypotension is a side effect of hypermagnesium. And then sometimes some insomnia. That muscle weakness is really big. This is very rare unless they are on magnesium, bless you. Unless we're literally giving them magnesium and we went too far. This doesn't really happen because of eating too much of it. Usually this is only in patients that are on the medication or they have kidney failure. Okay. And usually we don't see this until it's like over 4. Yes, ma'am.
I have 2 questions. So first, the I forgot the one. Is the only like definitive way to test them like with lab values? Because I think she was saying like the triple sticks or whatever.
Yes. So you're going to see signs and symptoms, but you're not going to know exactly what's causing it until you get labs. Mm-hmm. Yeah. You would expect. So if you saw chopsticks and Trousseaus, you would expect hypocalcemia and hypomagnesemia.
Okay. And then for the mag sulfate, that's given if your magnesium is too low.
So we can give mag sulfate if your mag is too low. We can also give it for preeclampsia in pregnancy, or we can actually also give it in severe respiratory distress because it relaxes the diaphragm and helps you to breathe a little bit easier. So those are really the only, you don't see it given a ton in hypomagnesium is not super common. Okay. And so we usually give it more in pregnancy or in respiratory distress. Or y'all remember what we talked about with EKG? What arrhythmia you give magnesium for? Anybody remember?
No. Hold on. I think it's happening.
Torsades. Torsades. So that's the other treatment for mag. Okay. All right, so what is your role in electrolyte imbalance? Well, if you're doing the assessment and you notice one of these things, you're gonna recognize what it might be. You're going to notify the nurse and or the physician. depending on what your hospital policy is, who you go up the chain of command to first. Okay, if you're concerned about something, you should know which focused assessments to do and perform those focused assessments. If there's orders on giving replacement labs, you are able to give any of these replacement labs, okay? And then just monitoring vitals, I's and O's, daily weights. All right, questions on that? Okay, I know y'all told me you didn't like math before, so let's just do a practice math, because I's and O's might be on your test, okay? So you have normal saline infusing at 125 mLs per hour, and then you have 150 milliliters of an antibiotic infused over 1 hour. So during your 12-hour shift, how much fluid has your patient received? So how do you calculate this?
125.
So 125 times what? During your 12-hour shift.
Oh, 12.
So what's 125 times 12? 1,500. What about that antibiotic?
150.
How many doses did they get of that? Just one. 1650. Okay. All right. Now we have infusing at 150 an hour. They got a bolus. They got 75 milliliters of Zosyn and 150 of Flagyl and 100 milliliters of Phenergan. You were busy. Okay. Okay. How much fluid has my patient received in this one? So what about my normal saline? 150 times 12 is what? Trust me, I'll do the math. Okay. What about that bolus? So what do? We add 1,000. Okay. So that's 2,800. And then what about all those other medications? Just add them up. Okay. So plus 1 times 75, 1 times 150, 1 times 100. So what's that? 2125? Okay.
Already 21 and 28.
150 times 31.
So we've got 150 times 12, that's 1,800. We give a normal saline bolus of 1,000. Then we give plus 75, plus 150, plus 100. Oh, that's 3125. Oh, yeah, why 2125 is less than 2,800? Y'all giving me bad math. It's because you looked at the answer and I was wrong.
It actually has it wrong.
Yeah, I know, that's why y'all were looking at that, and so that's why you got it wrong. Look, I just typed it in wrong. Okay. Okay, so now we have oral intake. Does oral intake count on I's and O's?
Yes.
Yes, okay. All right, so we have normal saline infusing at 75 times 12 is what?
900.
900? 900, okay. Okay, 900, then what do we do with all those PO intakes? So we add them. But 2740.
Do you add the oral intake if it's asking for what the guide is?
Oh, you're right. It says, I said how much fluid has your patient received IV.
Oh, okay, well, the first thing she said was. So it's not.
You're right. I did that. I also, it's because I just copied and pasted that that question in the last one. So during your 12-hour shift, how much have they received IV? 900. How much have they received total? 2740. Good catch. It's because I just copied and pasted that. Okay. That is everything. What questions do you guys have? Nothing?
Are we gonna have flow rates?
Flow rates.
Did we see that's happening in your semester or am I?
Well, this